And let's start, friends. Don't write anything, please. I ask you, just name and listen me, because all the information which is necessary is given. Now listen me carefully. Statistical information is show that this is the second most usual female cancer after the lung cancers. But mortality of it twice less than mortality of the lung cancers. Incidence today, look here please, in different countries it is absolutely different. In our country, in Armenia, incidence is huge, 20-25% in 200,000. In average in European countries it is near the 5-6. In India it is less, 2-3% in 100,000. It is connected with several factors, risk factors, which I will introduce you a little after. Now about the age contribution, approximately 50, 55 and after. But what is important, last 10 years we see the young female breast cancers before menopause. If previously it is post-menopausal problems, mainly, now today before menopause we see formation of the breast cancers. 5-year survival of this problem, approximately, if we will take all type of the breast cancers, by the way, it's not correct, because it is connected with the localization of the cancer. Absolutely one situation in local form, more than 70% survival. And absolutely another situation in the diffuse forms, approximately 20-25% survival. And today I will show why. Because there are the huge problematical ways of the metastasis, which we will introduce a little later. Now let's speak about risk factors. You know, first of all the breast cancers can be divided into two main groups. It is inherited, genetically determined, and it is acquired forms of the breast cancers. Let's start to speak about acquired forms. As you remember, first of all, why in our country, for example, so high incidence? Radiation level is very high. It is the atmosphere radiation, ultraviolet radiation, radiation connected with some minerals, for example, the basalts. It is the geological special structures, which is influence this high radiation, mainly gamma radiation. Let's say if there are high level of the radiation, it is shown that high incidence in the countries with high level, it is shown high incidence. Second factors, which is absolutely today we know that connected, it is for example smoking. We know that smoking is associated with breast cancer. Majority of the females today, in the previous times no, but today majority of the females with the breast cancer, it is the smoking persons. Very important, it is the medicines. Medicines, especially it is the hormonal medicines. It is hormone type of the treatment for post-menopausal treatment. For example, estrogenical treatment. The United States in the previous centuries widely used these hormonal treatments. Why? To keep the beauty. And 10 years investigations show that the females with estrogenic type of the treatments have twice, sometimes thrice more usual formation of the breast cancer comparable with the numbers. Genetical, you know, BRCA1, BRCA2, we can make today, it is the genes which is located in 13 chromosomes. And we can make the panel investigations and find them, Partly it is the chromosomes, the X chromosome associated type of the genes. It's like we can today, by high possibility, understand does the person have the chance to have the breast cancers or not. And then I will speak about treatment, surgery. You will see that we have prophylactic mastectomy, prophylactic, even double-side prophylactic mastectomy to prevent in the future formation of the breast cancer. That's a huge amount of the risk factors connected with external and repeated by the internal inherited risk factors. Now about, of course you must understand that some internal diseases, metabolical problems, endocrinological problems, same obesity, it also can be the cause, risk factor of formation of such kind of the problems. So remember about also epidemiological, all the pictures is given here. Now about classification of the cancers. Classification of the breast cancer is unique. There are histological classification, not clinical classification of the breast cancer. Histologically, there are two main forms. It is the benign tumors, it is malignant tumors. Both and benign and malignant divided into two main types. The lagged first type of the carcinomas or adenomas, if it is benign one. And it is the ducted lobes. That's a lobe form and duct form. Lobe form, it means it is located inside of the breast tissue. Duct form, it is located inside of the duct. That's it. We can have a benign adenomas, we can have and the malignant carcinomas. Let's start from the malignants. Benign tumors of the breast, it is the lumps of the breast. If you will need it, I will give you, I write the special lecture about it. It is the hyperplasia of the breast tissue, it is the metaplasias of the breast. I can give it for you, it's not included in your exams, it's not included in your final exams, but the malignant tumors we included. Malignant tumors we divided into two main types, local and diffuse. Local form of the tumors, it is the cancer in situ. It can be duct cancer in situ, it can be the lobe cancer in situ. What the difference between them? Ductal form, it's located inside of the duct. We see mucous membrane, cuboid epithelium, and inside of the cuboid epithelium up to the basal membrane, we have this low differentiated type of the cells, but which is not spreading to another layers of the duct, which is located only in the mucous membrane. The natural border, natural border of this cancers, it is the basal membrane. It doesn't spread it deeper, but it can become to the spread it form, to the diffuse form. The more early you will recognize the problem, the more better will be your treatment. You can make, for example, segmental resection. Usually in case of diffuse form of the cancers, we make the total mastectomy. We don't make segmental resection. Now 1 minute on the histological pictures. Histological pictures. Brilliant. By the way, I put especially the histological pictures near to each other. This is the invasive diffuse forms, and this is the local cancer in the situ. And look, please here. First of all, what do you see? The lobular form, inside of the lobe, there are huge amount of the proliferated lobular cells. Mainly, guys, this is the gland cells. How you can recognize it? Round structure which is surrounded by the cancer cells, cancer in the situ, You don't see ducts. Here you can see ductular form. It is located inside of the duct. By the way, these duct forms divided into three main types. This is simple duct form. This is, we call cribriform duct form. It means it doesn't proliferate it all the duct. Inside of the duct we have a lot of apertures, like the cribriform structure. And finally, necrotic form. Necrotizated form during the time. It is just continuation of this previous picture, during the time because of the problem of the vascularization. That's why we can say we have here secondary canalization. Not the primary, but secondary, because of the death of the cells, space is open, and you can see, and by the way, guys, clinically, it will be stage of discharge from the nipple. Let's say then we will have necrotization inside of the ducts. This pussy, bloody liquid content will come from the nipple. In the first stage, then it is just the proliferation. We don't have any liquid which is pus because just the duct is closed by these proliferating cells and we don't have any necrotizated cells, no any liquid generally. Remember about it, by the way, it is the worst form, in the majority of the cases, exactly necrotizated forms of the local cancer gives the lymphoid metastasis and become to the invasive forms. Now look in the opposite picture. What do you see here? The same lobular forms, the same duct form. By the way, it is the specific duct form which we call tubular. If you remember my previous lecture, I say that the tubular form we have for thyroid cancers. papilloform, yeah? Then the unusual tubes, like the exocrine tubes is formed. This is exocrine gland, but we have unusual abnormal tubes. Why it is abnormal tubes? Because they doesn't open into outside. Normally, you know, your breast has milk evacuational tubes, yeah? They started from the ducts on the tip of each lobe, then they continues to the sinuses, and sinuses open like poruses. Yeah, 7, 8 porus in the tip of your tube. But this is tubes, which is blunt. They doesn't have association with environment. They doesn't open inside. This is abnormal form, remember please. And what, you can say, what the difference? Okay, now let's compare this lobular form with that lobular form. What do you see? Atypical cells. If you will look to these cells, you will see absolutely typical, yeah, round membrane, cytoplasmatical membrane, not so big nucleus inside of it, very good visible cytoplasm, which is surrounding the nucleus. In that picture, absolutely another atypical, abnormal, deformated cells, huge, great, big nucleus, no any normal cytoplasm is not visible. Let's say forms is absolutely same, but one is invasive form because we have low differentiated type of the cells. Second is non-invasive form because we have high differentiated type of the cells. But it doesn't mean that this one cannot become to that one. Can be, simply. It is only the problem of the time. Any breast cancer starts from the local form. Any breast cancer during the time can become to the invasive forms. Remember about it. This is very important. That's like histologically, remember please, problem can be firstly inside in the lobe or inside of the duct. It can be local, cancer in the situ, T0, yeah? It can be invasive. By the way, T-grade, a little after, then I will speak about the staging, absolutely differ from T category of any other type of the tumor, and you will see what the difference between the little after I will say it for you. Second type of the classification, it is histological classification. That's the first one, it is histopathological classification. We have ductal form, we have lobular form. We have the local form, we have the diffuse form. Local form of the breast cancer, it is cancer in situ. It can be inside of the lobe, it can be inside of the duct. Doesn't matter, both main types. Now, histological grading. Everything is simple, guys. 3 main grades. Grade number 1, high differentiation. Grade number 2, low differentiation. Grade number 3, anaplasmical type of the cells. Yeah? Mainly, of course, it is belong to the invasive form. In case of the local form, we see high differentiation. In case of the invasive form, we see low differentiation. Next classification of the tumors according to the histology, it is the receptor status. Let's say 3 main type of the receptors we can have. It is the estrogen receptors, it is progesterone receptors, and it is human epidermal growth factor 2. Let's say why it is important to make the hormonal therapy in the future. Yeah? If you understand the receptor form of the tumor, after you can use antagonist type of the hormones, which is connected with receptor, which is block the receptor and make the growth of these cells very high. Let's say receptor status is necessary not for identification, but it is necessary for future treatment. Of course, we do it immunohistochemically. That's why it is tissue oncomarkers. Let's continue, my friends. Now we come to the one of the most important questions. It is the staging of the tumors. And what is unique in the staging of the tumors? As you remember, previously, when we speak about any other type of the tumors, we say T0, or it is absent of the tumor, or it is cancer in the situ, not here. Here, T0, it is only absent of the tumor. For cancer in situ, we write T is. As I remember, please, that is specifically important. We must to mention, is it absent of the tumor? Because we make the wide screening test for all the, in some developed countries, all females, once during the year, make the screening test. For example, mammography. And you must to write exactly, if you write T0, it means no cancer. Not cancer in situ, but no cancer. So if you want to mention that this is cancer, by the way, how we find cancer in situ? Cancer in situ, friends, remember forever, it is incidentally finding problem, because usually it doesn't give any value. Usually it doesn't give any symptoms, except necrotical form, which I should say for you, then it gives the discharge from the nipple. Do you understand? For example, majority of the cases of cancer of the in situ, we find in the case of the benign problems of the breast. For example, there are some benign problem, you take the biopsy, and instead of the benign problem, you find the cancer. Why it's so? Because again, I tell you guys, namely, local form of the cancers is asymptomatical. I mean cancer in the situ, and it's not visible in X-ray. That's why these screening methods which is used doesn't show the cancer in situ. No, any type, only histology can show it. But if the female doesn't have the symptoms, why you must make the histology? Histology, it is not the screening test. Histology, it is verificational test. Do you understand me or not? That's why it is incidentally. For example, benign problem, you want to investigate it, and touch wood, of course, you find instead of the benign some bad problems. Only like this. Unfortunately, screening methods which we have today, mainly it is the X-ray, it is show the invasive form of the cancers. Invasive form of cancer, which is losing of the time. We can say which is losing of the time. We don't have today, for example, circulating oncomarkers which show exactly cancer in the situ. Another T characteristics is very simple. Look here, please. T1, it is the tumor which is less than or equal to 2 centimeters. T2, it is tumor from 2 centimeters up to 3 centimeters. T3, it is tumor from 3 centimeters up to 5 centimeters. T4, it is tumor which is, or doesn't matter which size is it, or it is 7 centimeters and more. 7 centimeters and more, it means we have the contactogenous spreading of the tumor into the anterior or posterior. Why not? Into posterior walls. It can come anteriorly into the skin. It can go posteriorly to the all layers of the thorax. Intercostal space, intercostal muscles, and finally into the thoracic cavity. About N, everything is simple here, guys. N0, no N1, intra-breast lymphatic tissue. It is so-called deep lymphatic system of the breast. As you remember, breast lymphatic system, we divide it into superficial, which is located in subcutaneous fat tissue, and intraorganic, which is located inside of the tissue of the breast. So remember, please, maximum, we can have the spreading of the tumor into the signaling lymphatic nodes, Zorgius. T2, it means minimum 3 groups of axillary lymphatic nodes involved inside of the problem. T3, it is much more than 3 groups, or contralateral, or it is spread into the mediastinal group of the lymphatic nodes, touchwood, or it can go to the liver. You remember we spoke together, and I teach you how the lymphatic drain is happening from the breast. Yeah? Remember, please, all superficial lymph drain only through anterior group. Deep one, we divided the breast into 4 quadrants. Superior lateral, superior medial, inferior medial, inferior lateral. From both lateral portions, again, mainly into anterior group of the lymph. Finally, 75% of the lymph, otherwise 75% of the metastasis pass into anterior medial group. But we have another ways, supraclavicular, infraclavicular, transmammary way, from one breast to another breast, intrathoracic way into the mediastinum, and finally descending abdominal way, only from inferior medial quadrant. It can spread up to the umbilicus, and from umbilicus by round ligament of the liver, up to the hilum of the liver. Awful fun. How you find it, yeah? First sign, it is not the breast sign, but it is portal hypertension, AST. The person comes with huge distension of the belly, with caput medusa, all another signs which we study together. And you find secondary metastasis inside of the liver. How you can understand that it is secondary? Only histological. Let's say, first of all, you will think that it is liver cancer. Then you will make histology, you will see that it is not liver cancer, it is the breast cancer. Let's say you will see glandular tissue. You will see the glands. about the grouping of the stages. Here I write for you, everything is simple, guys, don't write. Now look here, please. Stage 1. Stage 1, it is no any lymphatics. That's why we have T, size of the T approximately, or up to 2 centimeters, or from 2 up to 3 centimeters. It is local. It doesn't spread it into the lymphatics. Stage number 2, it is, as I said before, intra-organic lymphatics, or maximum 1-2 group of the lymphatics inside of the axillary region. That's it. We can say, or tumor which is equal to 5 centimeters. It also can be, for example, stage 2, no any lymphatics, but huge size of the tumor, up to 5 centimeters. Or it is less than 5 centimeters with 1-2 lymphatics inside of the axillary, or it is more than 5 centimeters. Let's say, guys, you must understand that these two situations, hey, don't write scientific work, hey, listen. These two situations opposite each other. Both is worse. Like surgeon, I tell you, it's much more better to have local tumor, but big, comparable with a small tumor, but spreading. Anyhow, we have sometimes little after, then I will show for you clinical forms. We have sometimes the situation that the tumor is absolutely non-identified, like cancer in situ. But in real case, it's not cancer in situ. It is spreading to another layers, but it doesn't form the volume. It is diffuse. Let's say from outside, for example, you will make palpation of the breast. You will, I don't know, try to find anything. You will not find anything. Breast will have the normal size. Tissues will be kept, but it will be diffuse cancer. Of course, it's much more better to have big local structure, which is possible to resect it, to remove, and to decide the problem primary by surgical treatment. Then we come to stage number 3. Unfortunately, here situation is awful. Let's say we have more than 5, approximately from 3 up to 5 lymphatics inside of the ipsilateral axillary groups, or even it can give the contralateral, or it can give transfrontal. But anyhow, look here, please. No any far metastasics. That's why we speak about lymphatic metastasics, but not about far. And finally, of course, then we speak about 4th stage. It means we have the distant metastasics, or also it is possible, guys, exact invasion of the tumor into the walls of the thorax. Or from, so let's say, we can have or distant metastasis or contactogenous form of the metastasics. Yeah? Then it is grow into the skin. It gives the special clinical forms, for example, the inflamed form of the tumors, which is very resembled to the mastitis. Little after I will show for you. Or it is much more worse, it is growing inside of the mediastinum or inside of the thoracic, I mean the pleural cavities, yeah, or in mediastinum or in the pleural. Generally from the breast, mainly it is grows into the pleural sacs, yeah. But lymphatigeneously can be spreading into the mediastinal lymphatic nodes also. Let's say, remember please about staging, yeah, it is last stage which I showed. You can see it is the exact grow into the bone. Let's say tumor is spreading into pectoralis major and minor, and after it is goes to the intercostal muscles and can continue into the thoracic cavity. Anyhow. Now about clinical forms. You can say me why we need to have the clinical classification. Then histological, is it not enough? No, it's not enough. Because according to the clinical picture, we can decide which form of the treatment and which part of the treatment is much more effective, and little after I will show it for you. As I remember, please, majority, approximately 70 up to 75% of breast cancers, it is clinically, look what I say you, clinically local form of the cancers. You remember before I say for you, histologically, cancer can be local cancer in the situ, and it can be invasive. But we speak now about clinical characteristics. Then I look in the breast and find only lump inside of the breast. Clinically, I decided that it is local. Histologically, sorry, I don't know. Maybe the tumor is spreading into the lymphatics. Maybe even it is, but clinically, I see the local form. I say, please don't mix the clinical local form and histological local form. It is absolutely different. Then we say clinical local form, we mean lump inside of the breast. What is the main sign and symptoms of such kind of the tumor? Number one, volumetric process, abnormal, which is normally must be absent, which is by density differ from normal tissue of the gland, which can give some inflammational signs in the skin, usually which is painful. Sometimes we can see the skin problems. For example, you can see intrusion of the nipple into the tissue of the gland. We can see discharge from the nipple. As I say you, that is mainly according to inflammational processes. It can be inflammation in case of cancer in situ. It can be inflammation in case of the invasive form. Anyhow, we have some necrotization. If no necrotization, no any discharge, then what I need? Or invasively, this tumor will perforate the ducts and kill the tissues, or we will have inflammational process inside of the tumor. Discharge can be different. Usually it's not so big. It is small drops of the bloody, hemorrhagical, or pus. This is the main sign and symptoms which we see in the case of the local form, or so-called lump form of the breast cancer. There are special signs. I write it here for you. Yeah, for example, Kenning's one. For example, Mikulicz one. What does it mean? Kenning one, for example. Then you give the supine position. Usually, it is deformated the breast. Why? Because the tissues goes to the backside. Usually, in the vertical position, the value of this lump is not so good visible. But then you give the supine position. Tissues goes to the backside. And the abrius, the form of this lump, is greatly visible under the skin. Yeah, even without palpation, you can see it. Usually, then you give the supine form, skin picture is changed. Usually, you see it is become too pale. Why? Because the structure stress it from inside. Vascularization is decreased, and skin form, so-called, it is symptom of the pale table. Let's say you see some quadrangular or round form of the protrusion from inside to outside, which is pressed locally the skin and make it pale in the region of the tumor. Of course, you must understand that this is resemble for big lumps, usually 3 centimeters and more. If there are small lumps, small process inside of the breast, no any such kind of the signs will be invisible. Let's say, remember for you, it is T2. Starting from T2, yeah, then we have 3 centimeters and more, yeah, of the tumor. The signs which I mentioned for you, it is palpational signs. They will be visible. Let's say, remember, please, once again, first clinical form, we call local form, otherwise we call it lump type of the breast cancer. Now look at the next pictures. What do you see here? It is the classical mammography. And instead, I can show for you now the mammography of the local form of the tumor. Please look here. This is the local form. That is the local form. This is benign, but anyhow it is local. Now compare these pictures, for example, with that one, or with this one, which I show for you in that picture. Diffuse form of the inflammation. What does it mean, friends? You can look in the breast, you can palpate in the breast, and you cannot find any difference with the normal picture. No any deformation, no any changing of the density. In majority of cases, it will be changed, but can be also without any other signs. Why? Because no any local formation. We have diffuse spreading through the whole breast tissue. Fortunately for us, usually it is show itself by some common wounding of the breast. It is stand hard to palpate. Instead of soft tissue, you see scot. Like after the plastical reconstruction. Then we use the implantation of the breast. Of course, you understand that the breast tends from behind, from retromammary space, and the tissue of the breast stand more dense, not so soft. It is, by the way, one of the meanings why we do it, to make fixation of the breast, to give the position for the breast. Not only beautiful form and size, but also fixation. Let's say, remember, please, in approximately 30% of the cases in diffuse form, of course, friends, you must understand that if there are diffuse cancer, finally we will have inflammation, because that is the cancer which has damaged the vessels, which has damaged the nerves, which has damaged the normal tissues. But in primary stages, no any signs usually. It's a much more, I'm sorry, but I can say much more happy the females. It's hard to say happy for the person who has the cancer, but much more happy the females who has the local form, lump form. Because the lump form of the cancer will show itself. Diffuse form of the cancer in the primary stages will not show anything. Yeah, finally we will see huge amount of the problems. For example, exactly, secretory form of the carcinoma. I show it here for you. Absolutely same to the acute type of the tumors, which we study, for example, for gastric tumors, or for lung tumors. That is the type of the tumors which is producing different type of the hormones. Remember, please, it is showing itself usually by endocrinological sign. All these are the endocrinological signs we discussed today. If it is possible, close the door. Now look, please here. What is the logical conclusion of the diffuse form of the breast cancer? That is logical conclusion. We call it inflammatory breast cancer. Inflammatory breast cancer, it is just the development of the diffuse form of the breast cancer. What do you see? Huge inflammation, which is spread through the whole breast tissue into what it is resembled, mastitis. That's like when you look in the breast and you know what is bad. Approximately in 20% of the cases, it is developed for lactational breast. It is last trimester, young forms. You remember I told you, last 10 years, we see that it is stand younger. And sometimes it is happen in the same time with the mastitis. There is happen the mastitis. It is females with milk production. Yeah, it is lactational time, last trimester of the pregnancy. Yeah, and external sign and symptoms of this inflammatory form of the tumor absolutely same to the acute mastitis. For both cases, we can say that there are what? Abscess, there are inflammation. Only if you will make here histology, you will find the typical cells, and you will understand that this is not inflammation, this is something called budget cancer. You know, I have the 2 years before a patient with this budget cancer. She is treated approximately 3 years by dermatologist. Because this is absolutely same to eczema. I know what is the eczema, skin inflammation. It is specific eczema which is located in the region of areola and nipple. Why this happened? This is metastasizing of the tumors into the superficial, subcutaneous lymph nodes, which is mainly located in the region of areola and nipple. If you remember, I told you before that lymph nodes divided into superficial groups and into the deep groups. Let's say, if the breast cancer gives the metastasizing into the superficial groups, how it is shown clinically, small ulceration and inflammation of the skin in the region of areola and nipple. And unfortunately, these persons lose a lot of time because of wrong treatment. They make the dermatological, some creams, after it will not go to the secondary metastasis, so huge problems is not happening. Next one, guys, the erysipeloid. You know, you study, the erysipeloid infection, which is the streptococcus form of the beta hemolytic form of the streptococcus. Again, skin problems. Again, you can see absolutely erysipeloid form of the inflammation in the skin, diffuse inflammation from the margins. It is much more developed in the middle part. It is less developed, and it has chronic form. Yeah, erysipeloid has the remissions and has the recidives. Of course, this one doesn't have any remissions and recidives. It can only develop. It cannot be decreased anyhow. But the picture, it is very, very resemble same to the erysipeloid. You understand that the erysipeloid has another locations mainly. It is face, it is the lower extremities. The places with bed, it is, we call English term, I forget. We call it inflammation for the parts of extremity with low supply. Yeah, for example, extreme acro form of the inflammation. Yeah, terminal form of the inflammation. Like we say acromegalia, it is the hyperplasia of the terminal portions. Yeah, it can be face, it can be extremity. Here we have acro-inflammation. Why lower extremity? Bad venous lymphatic drainage. The worst lymphatic drainage we have in the lower extremity. Not so good in the face also. That's why erysipeloid mainly is shown not in the breast region, of course, but in another region. But again, I say, by the picture which you see, it is very resemblant. And of course, this is diffuse form. This is diffuse form. That's like you cannot palpate it any lumps inside of the breast. It is diffuse, like the inflammation, like the Paget form. This is three forms, which is continuation of that one. Primary diffuse form of the breast cancer. That's like during the development, according to, that's like these two, as you understand, these two. It is the spreading of the metastases into superficial lymph nodes, which is shown in the skin by the inflammation. That one is complete, spreading into all breast. Let's say, and intraorganic and subcutaneous lymphatic nodes is, of course, damaged by the diffuse spreading of the cancer. Remember about it. Let's continue. The piloid form of the cancer. It is unique form of the cancer. Why? Because that is mixed cancer. Till now, we spoke about cancers which is originated from the gland tissues. The piloid cancer, it contains and stromal cancer elements and glandular cancer elements. That's why it is mixed form of the cancer. By the way, piloid cancers can be benign also. That's why we can see the hyperplasia of the breast tissue, which is contained, for example, stromal connective tissues and glandular elements. Yeah? But in approximately 60-65% of the cases, it is the malignant form of the tumor. And if it is malignant, it is the awfully spreading and gives, if another tumors of the breast gives the lymphatic metastasis, this one gives the hematogenous. Why? Because it is inside of connective tissue. Majority of the vessels located in the connective tissue stroma, not inside of the tissue of the gland. In tissue of the gland, we have lymphatics, but we don't have the big vessels. Big vessels located out, like thoracical lateralis, supraclavicular, intercostal vessels, they located in stroma, they doesn't locate in the tissue of the breast. Let's say, remember, please, this is the so-called clinical classification. It's like clinically, if we will make conclusion, we can say that all the tumors divided into three types. It is the local forms, it is different forms of diffuse tumors, and it is mixed form of the tumors. I write here also the secondary tumors, which is come to the breast. Of course, you understand that not only from the breast, the tumor can be spread into other organs, but from another organs it can come. For example, from the lungs. Yeah, you know. Yes. It is one of the most usual type of the spreading of the cancer from the lungs to the breast. How we can identify it? Only histologically, no any other way. If I will make here, for example, clinical investigation, I will not understand what does it mean. No, I can understand, for example, it will be associated with respiratory signs. It can be shown by cutting, by hematoptesis or something else, which is showing involving of the respiratory system. But no any exact sign, yeah, which is show for me that this is the problem which is originated from another place. Externally, it will be same to local or same to the diffuse forms, comparable with the form of the metastasis. Now let's continue, guys, about diagnostical investigations. Of course, we started from collecting of anamnesis, and what is important here, family anamnesis. Family anamnesis is very important to understand, is it belong to inherited forms of the breast cancers? Today, you know, in the United States mainly, it is very practicated to make the prophylactical surgical operations. It is the simple form of the mastectomy. Then we remove only the breast without the pectoralis minor minor and without axillary lymphatic nodes. Of course, after this, we make plastical reconstruction of the breast, yeah, to give the normal form of it. This is today very widespread in our country also. All these panels, we call it panel of the genes, yeah, which is investigated. We know the locus of location of these genes. We can simply immunohistochemically find mutations inside of them. But in our country, for example, till now we don't make the prophylactical methods of the mastectomy because it's necessary to have the special law which is given, because today, for example, our law doesn't give us chance for the health person without the breast cancer to make the surgical resection. Yeah, so you must understand that this is the problems connected not with the medicine, but with the law. Let's continue, friends, now about the physical methods of investigation. Here there are gold standard. Number one, it is palpation of the breast by the quadrants. We start it from up and we goes to down by according to the watch
Clockwise.
clockwise, yeah. From up and to down. And secondary, we palpated all regional lymphatic nodes, mainly axillary. Axillary lymph nodes, 1 minute, look to me. I teach you, then we study topographical anatomy. Again, I want to say you. It is the inferior margin of pectoralis major by anterior axillary line, level of the third, fourth ribs. This is the place of location of the anterior or medial group of the lymphatic nodes. Except it, we palpated all another 4 groups. As you remember, it is posterior group, it is the lateral group, it is the central group. All of them can be involved. 5th group, if you remember, we call infraclavicular or apical group of the lymphatic nodes. We palpated supra and infraclavicular group of the lymphatic nodes. Sneha, I do something funny? No, if you have some original ideas about it, I speak about the main problem of the females, oncology, and it gives so many positive emotions for you. So fantastic. Unfortunately, I'm not the specialist in psychology. Otherwise, I can try to find the diagnosis. Okay, let's continue, guys. From physical methods of investigation, we become to the instrumental methods. About laboratory methods, I want to say you guys that only immunohistochemical methods, yeah, which is find, for example, the receptor tag, which is find the genetical mutations, which I said before. Let's say we work with tissue oncomarkers. We don't work mainly here with the circulating. We don't have specific circulating form of the oncomarkers which can show the problem for us. Even the 2-3, which is CA, yeah, they show mainly prognostical and the treatment values, but they doesn't have any diagnostical meaning of the investigation. Absolutely. Let's start to speak about the instrumental methods. Of course, you know, screening method, it is the mammography. We do it in 2 projections. It is craniocaudal projectional pictures, one in frontal plane, the second it is in horizontal plane. And in these 2 planes, we can make the very good methods of investigation with contrasting or without contrasting. If it is, guys, the discharge form of the cancer, we can make intraductal injection of the dye, and after this we can make the picture in X-ray. Yeah, for example, in this picture, it is the ductal contrast of breast, and you can see tumor inside of it. So you can see that breast is, duct is closed in several places, and it is shown that some obstructive form of the, we say, duct form, yeah, of the breast cancer, not the lobular form, but the duct form. A lot of pictures I put it for you here, which show the diffuse form, which show the local form of the cancer. You can see here, for example, local form. Here you can see diffuse form, which has the, I can say, main look. Look, guys, it is also important to mention. Then we say about diffuse form. It can be diffuse form by primary locus and diffuse form without primary locus. What does it mean? For example, this tumor started by local form, but then it is spreading through all and other parts. For example, that tumors which you see, it doesn't have primary locus. They have just, or much more better, it is shown here. Look, no any primary. You can say that maybe here it is much more visible, but anyhow, we don't have exact primary place of location. We have diffuse spreading it through the whole tissue of the gland. Let's say for that kind of the tumors, we see diffuse tumor without primary locus. Then we see primary locus but spreading of the tumor. For example, inside of the intraglandular lymphatic nodes, we see it is the local form. We just give the diffuse spreading. Yeah? Let's say remember about it. Another methods of investigation. Today, there are some methodics of ultrasound investigation, especially for duct form of the tumors. Unfortunately, lobular form of the tumors is not so sensitive to this method. Why? Unfortunately, because most simple method, no invasive, no any radiation, nothing. For duct methods, it is much more preferable. Why? Because usually there are liquid content. And as you know, or there are enlargement of the ducts. It is ultrasoundly detected structures. Just the soft tissue, you know, it is not so good detected by ultrasound. We must have the difference of the densities. In the case of the diffuse lobular forms, ultrasound doesn't work. In the case of the local and especially duct forms, ultrasound can find, like you can see here, the cavities with the different densities inside of it. The same method today can be used. We don't use it as like the screening method because, as I say you, the effectiveness of finding of the tumors is not so high. Angiographical picture, you can see, if, I forget to say you that there are the special clinical form of the angiomas. Yeah, for example, I think you see many times the hemangiomas. Yeah? The child which is born by the enlarged capillaries, which is great visible, like red color or blue color, some moles in the skin. Let's say we can have such kind of the angiomas inside of how it visible. 2 minutes before I speak about caput medusa, which we describe in case of such kind of enlargement of the vessels we can see inside of the breast. If it is located superficially to the skin, even this snaky form of the enlarged vessels can be visible under this. In 50% it can be primary tumors, which is originated inside of the breast. In another 50% it can be secondary tumors, which is vascular origin tumors, which is come to another regions of the liver. For example, from the same liver. But anyhow, remember, please, angiography together with, it is same mammography together with vascular contrast. And you can see, according to the normal side of the breast, in the tumor side, there are huge vascularization, and even the locus of the tumor is greatly visible in the picture. Samely, we can make the mammography with scintigraphical method of investigation. For example, here you can see scintigraphy. We use the radioisotopes, different type of the radioisotopes, for example, strontium. And in the same time, we make the X-ray, strontium accumulated inside of the tumors because they have good vascularization. And you can see the locus of it. Mainly scintigraphy we use for the finding of secondary metastasis. If it is primary tumor, we can use much more easy methods, the same CT, for example, MRI or mammography. But if there are secondary small metastases, scintigraphy is great method. I forget to say you about
Thermography.
About thermographical method of investigation. Today it's useful, especially in African countries, without the good development method of the other investigations, if no any other methods, thermographical investigation is very simple. You just measure the temperature of the skin. And above the locus of the tumor, usually you can see that because of high vascularization, usually we have the high temperature, yeah? But comparable, for example, here, low temperature, you can see it is normal picture, yeah? Blue colors. Let's say it means the temperature is low. If there are high colors, it is grow from blue to green, from green to red. Oh, different variants of the red, yeah? The more bright is it, the more is temperature. But of course, it doesn't give any differentiation from inflammations. Because in case of any inflammation, abscess, mastitis, we will see the same picture to the breast tumor. Let's go to the invasive methods of investigations. It is the histological methods mainly. We have different type of the biopsy. Fine needle, which is take the liquid. Core needle, which is take the small amount of the tissue. Incisional methods of the biopsy. Then you take the tissue together with the neighboring structures. Yeah, that's all methods of the biopsy can be used. Also, we can make cytological methods of investigation from discharge, which is come from the nipple. That's invasive methods we use for cytological or histological methods of investigation. Only these methods finally give you answer which kind of tumor is it. Let's continue now. Look here, please. As it is shown in this picture, all methods of the treatment can be divided into two main groups. First one, it is the local group, and second one, it is systemic group. Then we say local therapy, local treatment, we mean radiotherapy and surgery. Then we say about the systemic treatment, we mean three types of the treatment. It is chemotherapy, hormonotherapy, and it is immunotherapeutical methods of the treatment, which I will introduce you later. Let's start from the surgery, guys. Listen to me very attentively because this is not simple to understand. Then we speak about surgery, we must understand that today surgery divided into two main types. As I said you before, it is prophylactical methods and it is the curative methods. We don't make here any palliative surgical manipulation. No. Generally, remember please, border between surgical curative treatment and non-surgical we can say systemic method of the treatment, it is T3. This is third stage, yeah? Before it, we make the primary surgery, local treatment. After it, if there are the far distant metastases, mainly treatment is not surgery, non-resectional treatment. Now this curative surgery, not prophylactical. Prophylactical surgery, usually it is double-sided mastectomy. Because inside of both breasts, we have the genes, which is responsible for formation of this tumor. That's why we make double-sided. Curative surgery, in 99% of the cases, it is one-sided surgery. That's why you make the surgery only in the side. Why I say 99? Because as I told you before, in 1% of the cases, we can have transmammary passage of the metastasis. Then from one breast, tumor is spreading to opposite breast. So in that case, you make double-sided. Now, all surgeries, we can divide it into two main groups. Group number one, it is portional resections, or we can segmental resection, we call it lumpectomy, or group number two, it is total resection, we call it mastectomy. So remember, please, we can make local, segmental resection. Usually it is provided for benign form of the tumors, or cancer in situ, if it is found. I don't know how you find it, the cancer in the situ, and you can make local resection, for example, with continuous radiotherapy, yeah, usually external beam radiotherapy, which is kill the neighboring, if it is, there are spreading tumors, it is locally just influencing the region of the problem. But in majority of the cases, we make the total mastectomy, and more of this, right, or remember, total mastectomy divided into three main types. Number one, simple mastectomy. It means you remove only the breast without axillary resections and without removing of the sliding layers of the breast. I mean pectoralis major and minor. Only, open the brackets and write please, only for local form of the tumor without lymphatic spreading. That's why this is the stage number one. Stage number one, we have the tumor maximal size, it is 2 centimeters. no any lymphatic is not included inside of it. Or in the brackets you can write, same simple mastectomy, we do prophylactically, but in both sides. So we don't remove axillary lymphatics, we don't remove the tissues of the thorax. Second one, it is the modified radical mastectomy. I give the surgeries from the smallest one up to the biggest one, yeah? Modified radical mastectomy. Right place, it is removing of the breast together with axillary lymphatics, but without removing of the breast tissue, or without removing of the thoracic tissues. Without removing of the thoracic tissues. And the last one, it is radical mastectomy by Holstead. Radical mastectomy by Holstead. Right, please, it is removing of the breast together with axillary lymphatics and together with major and minor pectoralis muscles. Together with major and minor pectoralis muscles. Open the brackets and write, please. If there are contactogenous invasion into the thoracic wall, we remove also the part of the own layers. For example, the ribs together with intercostal muscles, yeah? It is understandable for you. So remember, please, these 3 volumes. Simple one, it is only breast. Modified one, it is breast with axillary lymphatic nodes. Radical mastectomy by the Holstead, it is both previous together with the sliding layers of the breast, pectoralis major and pectoralis minor. Right, please, technique of the surgery. I will start to explain for you technique commonly for all these methods together, but starting from some stage, this stage will be the removing of the breast. They will be different. In case of the simple surgery will be finished. In case of the modified, you will come to the axillary groups. In case of the Holstead one, after removing of axillary, you will remove the pectoralis major and minor. Now don't write anything, just look to me, hurry up guys, time is very short. Now look, we start from incision. Let's say, I speak now about total forms of the mastectomy. It is not the portional resection. Again, I tell you guys, nowadays, portional, for example, lobectomy or lumpectomy, mainly 99% of the cases, we do for benign type of tumors. In case of the malignant form of the tumors, mastectomy, it is choice surgery. Let's start from the incision. Now look everybody to me. Incision is semilunar. It is start on the level of the anterior axillary line in maximal upper point. And then it is surrounding the breast from 2 sides. By the way, distance between the lateral margin of your tumor, your patient tumor, and place of incision will be minimum 3 centimeters. So remember this size. We remove the breast inside of healthy tissues, not inside of malignant tissue. Generally, remember, it is not only for breast surgery, it is completely for any surgeries. During the removing of the tumor, don't cut the tissue of the tumor. Cut only healthy tissues. Because then you cut the tissue of the tumor. In my previous lesson I spoke, you make hematogenous metastasis of the tumor cells. You open the vessels, you damage the tissue of the tumor, and part of these cells can be simply spreading into the vascular, especially into the veins, because the veins have the low pressure. Now look to me. Incision is passed in up to the midpoint of distance between parasternal and sternal lines. That's once again, from anterior axillary line up to the midpoint of distance between parasternal and sternal line. For the persons with big breast, it can maximally extend it up to the sternal line. It is the lateral margin of the sternum. What after? Now you connected these 2 incisions to each other, you cut the skin, you come to the level of subcutaneous fatty tissue. Now inside of subcutaneous fatty tissue, firstly you form superior flap, then you form inferior flap. Now superiorly, inside of the fat, you start to cut the Cooper's ligament. As you remember, Cooper ligament, it is the ligament which is from the capsule of the breast become to the skin. And it made the fixation of the breast. How much from upwards you will destroy? Up to the level of the clavicle. That's why in the level of the clavicle, as you remember, we have the Gerald ligament, yeah? Which is started from upper margin of the capsule of the mammary gland and goes to the inferior margin of the clavicle. Let's say, once again, inside of fatty tissue, by blunt or sharp methods, you destroy the septus up to the level of the clavicle. In the level of the clavicle, you cut it sharply. Gerald ligament, superior flap is formed. You can turn it to the down. Now you start to make inferior disconnection. Again, in subcutaneous fatty tissue, you descend it to down, up to the semilunar natural skin fold, yeah, which is mentioned for us inferior margin of the capsule of the breast. From that point, bluntly, you apply the hooks in the inferior margin of it, and you turn it to upwards. You come to the retromammary space. Inside of the retromammary space, bluntly, using the tube first, because we don't have junction, yeah, between superficial fascia and proper fascia, which is covered the pectoralis major muscle. You start to separate it, the retromammary space, up to connect it, the inferior flap with the superior one. Breast is disconnected. During the work, you will ligate it, the branches of intercostal vessels, which is from retromammary space, enter inside of the breast, and the branches of arteria thoracalis lateralis, which is come from arteria axillaris. It is not hard to find it, guys. This is projected strongly by anterior axillary line along the lateral margin of the breast. Breast is removed. That's how you make the complete, and you remove the breast with nipple and with the skin, which is located between these two semicircular incisions. Let's say skin in this region, together with nipple, must be removed. You can say me why? Because in majority of the cases will be the lymphatic metastasis into the superficial group of the lymphatic nodes. We have special methods of skin-saving surgeries. Especially it is practiced in United States. Then we make the areolar incision between the black and white skin, yeah, semilunar areolar incision. That's why you make incision by upper margin of the areola, you descend the areola with the nipple to downwards, and under of it, you remove the breast from this aperture. Sometimes we enlarge this incision horizontally into two sides. Why this surgery is not so good? Because it shows the high possibility of recurrence of the problem. If the skin involved inside of the metastasis, if there are any inflammational cells of the skin, which I show for you, budget type of the tumors, diffuse type of the tumors, I don't know, erysipeloid form of the tumors, skin should be removed together with the breast. Let's say you remember how much we make. For example, diffuse erysipeloid form. You find the lateral margin of the tumor 3 centimeters more from two sides. Let's say, remember, border of your tumor should be minimum 3 centimeters far from the margin of your incision. This is the classical gold standard. Remember about it. Okay, now we remove just the breast. What is important, guys? Remember, even in case of the simple form of the mastectomy, fascia pectoralis, which is covered, musculus pectoralis major, must to be completely removed. Because the first lymphatic metastases go inside of the fascia pectoralis, and from fascia pectoralis, by lymphatic drainages, it is come to axillary lymphatic node. Let's say, along of all musculus pectoralis major, you make blunt or sharp separation of the proper fascia and completely remove the proper fascia from the musculus pectoralis. Now, breast is removed. Now you must to come to the second type, which we call the modified form. How you make the modified form? Look please here, you put the hooks in the inferior margin of the major pectoral muscle and maximally lift this inferior margin to upwards. As you remember, the 5 group of the lymphatic nodes, which we have in axillary region, we divide it into 3 groups. Inferior group, which is located in the level of inferior margin of the minor pectoral muscle. Otherwise, it is a subpectoral triangle. You remember, 3 triangles we have here, yeah? Clavipectoral one, pectoral one, and subpectoral one. That's according to this. Don't check my patience. You know, you will fly from outside, or from window, or from door. And you will choose which method will be preferable for you. Do you need it? I also think that no. Let's say. Let's continue. So once again, in first level, inside of subpectoral triangle, as you remember, we have three groups of the lymphatic nodes. Yeah, it is the medial group, it is the lateral group, and it is the posterior group. In second level, we have central group, which is located just in the midpoint, geometrical midpoint. And in last one, it is apical group, which is located, as you remember, between your clavicle and first rib. Yeah. As you remember, your fossa axillaris has pyramidal shape form. Tip is looped to upwards and medially, base is looped to downwards and the lateral. Classically, remember forever, guys, we remove first only level of the lymphatics. It means completely medial group, completely posterior group, minimally lateral group. Because here you must be very careful, because lateral group, it is responsible for the drainage of the upper extremity. Previously, for example, Holstead is written that you must make all removing of all these three group of the lymphatics. But what it gives, I put here the picture which is show for you the lymphostats, but of course it is not so huge lymphostats. Right-sided surgery, left-sided surgery is performed, and if you will compare now the size of the generally, but guys, don't be so much confused by this. No any mastectomy without lymphostats. No any mastectomy. Other question, this I mean with removing of the lymph. Other question, this lymphostats is good, good develop or less. For example, this is acceptable. This kind of the lymphostats is acceptable, much more harder than you completely remove the lateral group, and it gives the elephantism. Complete lymphostats of the upper extremity. Huge problem, yet till now, approximately 20% of the cases, it gives the necrotization and the amputation of upper extremity. That's why again I tell you, it is very simple to be recognized. You palpated, guys, the cervical neck of os humerus. Here is located two tendons. Look, tendon of the short head of the biceps and tendon of the coracobrachialis. Just in the surface of these two muscles, tendons, there are the lateral group of the lymphatics. Don't remove it. Otherwise, it will make the big problems. Second level, if you remove the apical one, partly the lymphatics go exactly to the, central one. Partly lymphatics go to the apical. If you remove apical one, it gives the complete lymphostats of the upper extremity. That's because all four previous mentioned group of the lymphatics drain into the apical. Apical we call also infraclavicular. Let's say from these five groups, again, I suggest you don't touch the lateral one, don't touch the apical one. Otherwise, it will give the huge problems. I think from the surgery, all of the another specificities of surgical treatment, you will find, guys, not so much time to speak about hormonal therapy. I write the schemes, I write the main. Herceptin you will use the another type of the receptor blocker, for example, anti-estrogens, anti-progesterones. This is good because growing of the, especially of course, this kind of the tumor we use for diffuse type of the cancers, if there are the metastases. Because if no metastasis, you make the general resection and removing of the tumor, and you don't use any such kind of treatment. But if there are metastases, it can be lymphogenetical metastasis, it can be distant metastasis, doesn't matter. You use the systemic method of treatment. It can be hormonal therapy, it can be immunotherapy, it can be or target therapy otherwise, or it can be the chemotherapeutic treatment. About chemotherapy, again, the main medicines, the main groups, usually 3 or 4 chemotherapeutic medicines we use for the effective treatment. Radiotherapy, guys, it can be like external beam, usually 90% of the cases we make external beam, and we use it after the primary surgical treatment. You know, the best method to kill the cancer cells inside of the lymphatic structures, it is the radiotherapy. It may be locally, for example, you focus it locally into the mediastinal lymphatic nodes or into the axillary lymphatic nodes if you don't remove it. Unfortunately, one complication, again, lymphostasis. You damage the lymphatics, and if it will be high dosage, more than 3,000 gray, and in long time, of course, it can give also. Again, don't focus the radiotherapy into the lateral group. As I say you before, it will give the big problems. You can say me what to do. Use the chemotherapy, use the immunotherapy, use the hormonotherapy. If you see that the problem is spreading into this group of lymphatic nodes, use the systemic methods, not the local methods of treatment. About lung cancer, I don't think that now after